Welcome back, everybody. Now we're going on to our next talk, a very topical subject, COVID-19. So much has been happening in the last several weeks to months, and we're very lucky today to have two speakers that will be going through some question and answers. We've got Dr. Steve Ritchie, who is an infectious disease specialist at Auckland DHB. And of course, we have Dr. Bryan Betty, who is our medical director of the Royal New Zealand College of General Practitioners. So what we've done is that we've got a primer slide set. A primer slide set which we will begin to work through. So type in your questions as we go along and we'll get through as many as we can. Thank you. So Stephen, if you could just start off the discussion.
Sure, no trouble. So hi everyone. I'm sorry I may not be as prepared as I had hoped. We've had a terrible few weeks here at the hospital, as everyone else has, preparing for the onslaught of COVID. And we initially sort of suggested that we would do a Q&A session through the Goodfellow unit because a few weeks ago, a lot of the calls that we were receiving, that I was receiving when I was on call, demonstrated a bit of a knowledge gap out there, but that's no longer the case, of course. Everyone now knows everything. So I probably don't have too much to tell you to answer the first few questions, but I'll just go through, just try and explain a few very simple things from my perspective. We're all worried. We're all worried about our families and loved ones and ourselves, and our patients. And I'll just try and supply a bit of data to show why I'm anxious and not sleeping well, but still able to get 6 or 7 hours a night, despite the problems that the world faces. So this is a cumulative graph of cases in New Zealand. You'll know it's not quite, see that it's not quite up to date because I finished this yesterday. And also it's the cases reported to the WHO, so there's a 24-hour lag, but it shows that we are entering a phase of increased growth, exponential growth in terms of cases. A lot of that has been due to fairly young people, well people, returning to New Zealand, and they've come from countries, of course, where there's lots of disease, and some of them are bringing them back with them. So our exponential growth is not quite the same as was seen in some other countries around the world, where they've got primarily community spread. But I think comparing us to Australia is worthwhile because Australia have a similar sort of system. Their approach has been similar, their timelines have been somewhat similar. And that's the reason for using the WHO data, is so that I could directly compare New Zealand here in blue with Australia in green. Australia have got the same issue. They have a lot of return travellers coming back bringing disease with them. But you can see that Australia are ramping up, larger population size of course, but they're ramping up more than we are, and perhaps they have a lead time, or perhaps we're a week behind. Maybe we're 7 or 8 days behind them if you think of where we are on this kind of curve. It provides to me some sort of suggestion of where we are heading. I think our curve will continue to go up now that we do have little clusters of community transmission going on. It's funny, but who would have thought, well, not funny at all, but who would have thought 4 to 6 weeks ago that we'd be looking at Wuhan and the Hubei province as being an exemplar of sort of a best case scenario. But I did just want to show this picture. This is a timeline of the cases in Wuhan. The orange bars, these orange bars are the cases once they've been confirmed. So at this point, they've had a positive test, they've entered the hospital system, they have illness, etc. The grey bars on this graph show the date of the onset of symptoms. And just to show that we are diagnosing cases here, we're diagnosing a lot of them, but the number of cases that we're seeing here represent the onset of illness and transmission a week or so before. So when we find cases, we're actually kind of chasing our tail. There's already more out there. And I think that's why countries like Italy, Spain, United States, etc., have ended up in a bigger hole than they might have hoped, because they're a bit late in making changes. So Wuhan, Hubei, China, have managed to put a bit of a lid on COVID, and their little orange bars were heading up into the hundreds here, obviously a much bigger population size. But I do think that our recent lockdown has occurred kind of around this sort of area, not this sort of area, which is when Wuhan locked down. So they locked down on these dates here, these yellow dates. And so it is possible that over the next few weeks we'll see a bit of a rise. We'll see a rise in cases, I think, but then followed, fingers crossed, with a fall. Here in blue is the epidemic curve for China, showing that cases have generally gone, and then the overlapping epidemic of cases elsewhere in the world. These early phases were in Europe, and now we've got North America and other parts of the world contributing. So Wuhan, Hubei, China look oddly now like an exemplar of control. As of the 26th of March, I've got one more slide after this before I'll go back to you, Grace. As of the 26th of March, this is the situation in Hubei province, which up until very recently was the most affected area on the planet. And they'd recorded 3,163 deaths amongst 67,800 cases. So the case fatality rate, 4.6%. That's simply this number here divided by this number here. And that's an awful prospect. But there will be, and there are, a lot of other cases that occurred in Hubei province, a lot of other infections that were minor. For whatever reason, the person didn't seek medical care, or the doctor didn't arrange a test, or the test wasn't performed, etc. And so I think we are looking a little bit at the tip of the iceberg. It's very, very hard to work out what this proportion are, but it definitely exists. We know that. There's also going to be a much, much bigger part of the population who had the opportunity to be exposed. They're in the right part of the world, and these are respiratory viruses, so they spread around pretty easily. But for whatever reason, weren't actually exposed or didn't become infected. And this is a very large number. So in Guangdong, a massive city, their fever clinics, which will be similar to our community testing centres, their fever clinics tested 320,000 people, and their positive return rate was actually very low. So it does seem there's a very large chunk of the population who was spared in China. And this is the last bit. So Hubei, if we look at their number of cases and the case fatality rate, it's frightening. But if we put it into the perspective of the total population of Hubei province, 59 million, then the mortality rate, that is the people dying of COVID divided by the total population number, is low. Again, still bad news, but it's low. And the case rate, 0.1%, equates to about 1 in 900. However, most of the cases were in Wuhan city, not in the outer-lying areas of Hubei province. And if we apply exactly these numbers to that population of 11 million, we get a higher mortality rate and, of course, a higher case rate. The true figure is somewhere in between, or perhaps lower, because we haven't added in those low-level cases that weren't actually diagnosed. And then if we apply that to New Zealand, and this is best case scenario stuff, and it's just me doing simple maths using the numbers I've just shown you, then if New Zealand operates like Wuhan City, we'll have that many cases. If we're more like Hubei, the proportions are that many cases. This is I look at this as thinking this, if we get out of this with these sorts of numbers, I think we'll have done a good job actually. If we get out of this with lower numbers, then we've done a brilliant job.
Okay, a couple of questions have come out of that, but before I speak upon them, just to let everyone know out there in the audience, if you are using a smaller mobile device, you have to remember that to view the screens, you need to do your swipe, which will shift you between the speakers and the screens. Now, is there any, with regards to New Zealand, how do you see our modelling when we compare ourselves to, for example, Italy versus to places like China? Where do you think we're tracking at the moment?
I think it's too early to say.
Okay.
But our lead-in is looking a little bit more like more of the China end of the spectrum than the Italy end of the spectrum. So by the time Italy realised they had community transmission, they were inundated. Their hospital systems were overwhelmed, within a matter of days. And the time frame of this has been short, right? We think of, this seems like it's been going on for ages, but Italy's upswing in cases was 3 to 4 weeks ago. It's horrific. Whereas we've been, again, because we're bringing travellers back, the numbers in New Zealand, don't all represent community spread like they have in other parts of the world. And so, our hope, my fingers crossed, the reason I can sleep at night at the moment is that, we look like we're tracking a little bit more like the China end of the spectrum so far, and a lot of our cases are linked to overseas travel. And we know that disease is rising rapidly in other parts of the world.
Okay.
If we brought our travellers back in January, then we would have very little disease.
Sure, appreciated. Now, we're obviously currently in lockdown for 4 weeks or so. So how would you expect us, I guess as a nation really, once that official lockdown finishes, where do we go from there in terms of projection of how long the disease might last for? What services do you see still running in the community?
Yeah, look, I
big question.
Yeah, literally have little ideas other than the vague ones floating around in my own head. There is modelling out; it's been referred to. I haven't seen it. The media have suggested that we will peak, April, May in terms of cases, and that's clearly more than outside the 4-week lockdown. I sort of see the 4-week lockdown, and again, I'm not a public health physician, I'm not an expert in this, but I kind of see it like almost like an experiment, and a good, potentially a good one. If we can get cases all the way down and control the amount of disease so that our primary and secondary healthcare systems can cope, if we can manage to contact trace and do lots of testing, find cases, quarantine, put a lid back on it, then I think we can be cautiously optimistic. Can we do that in 4 weeks? I'd be surprised. I think it might take a few weeks longer than that, based on what's happened in other countries that have had good results with this so far, be that by luck or some or their amazing public health measures. I think
Grace, can I...
control is likely to be in place for a long time.
Grace, can I make a comment?
Yes, yeah, absolutely. Please do, anytime.
Yeah. Being on the national groups down in Wellington, one of the comments I'd make, and one of the things about the lockdown, is when you start to get new cases, as they start to track down, contact tracing becomes a lot easier. So you can start to track who may have been in close contact and who you can isolate. So that's going to be an absolute positive. However, one of the things I would say for general practice and general practitioners who are out there, my belief is this is longer than 4 weeks.
Yes.
I think one of the things that's been grappled with at the moment is how to step down from this and what that actually starts to look like. And there's been a team put together at the ministry over the last week to really start to look at those issues. I mean, if you go back to the Spanish flu in 1919, the great example, I think it was St. Louis in the States, where they had an initial peak, came down, they reduced all the lockdown, they've gone into lockdown, and then they had a second peak. So what you're trying to avoid is a second surge in cases. I mean, it'd be fair to say I think this is going to end when there's some sort of herd immunity, we have a vaccination, or there's some sort of treatment, to be honest. But I think, 4 weeks, it's longer than 4 weeks at this point. Yep.
All right, we've got a few questions about the flu vaccine. So Bryan, perhaps you could speak on the space with regards to current supply. What's happening in that?
Yeah, look, I mean, it's been a slight issue as to where vaccine gets to and how it gets to. Basically, all the vaccine that has come into the country, which is about 800,000 doses, has been distributed around the country as of yesterday. I had assurances off the ministry that was the case. There's a next shipment is not due for 1 to 2 weeks. The vaccine that's been distributed needs to be obviously prioritised for those at-risk groups, the elderly, those with comorbidity, and those who are eligible. There has been an issue with where the vaccine has ended up, and there could potentially be centres or places where the vaccine's not been used, but it's in fridges. So the ministry became really aware of this yesterday. I was on the phone all day to them about the situation. They are working very hard to try and rectify the situation, try and get the vaccine to where it needs to be. I know there's been problems in Northland, Rotorua, Wairarapa, parts of Wellington. all over the place. So yeah, the ministry is aware that it's a problem, and they have assured me they're trying to sort it out with the redistribution of vaccine. There are certain issues that people may not be aware of, that if, for instance, pharmacy has got vaccines available and they're not being used because of lack of through traffic, it's actually illegal for them to pass it on to general practice. The local general practice far short and got their flu clinics backed up. So there's these sort of system problems that have emerged from regulation from the past. Again, they're working on lifting those regulations in the next week, hopefully, get rid of them so that vaccine can flow more easily into those areas that need. I think it's incredibly frustrating for general practitioners that this has occurred. I think the system was unprepared for the amount of demand. The fact we switched to virtual and a lot of vaccine clinics were suddenly needed to be booked ahead and not drop in. And so these changes, which have been very, very rapid and closely spaced, have really sort of produced problems in the system and the distribution system, which, as I said, the ministry is assuring me they're trying to sort out now. So that's where we're at.
Okay, great. We've got a few more influenza questions, which I think we'll just pack together before we move on. Now, a quick question with regards to just comparisons of mortality of influenza versus COVID, and also if there are any clinical symptoms at this particular point in time that are more common for one or the other.
Stephen, do you want to answer that first? I've got a couple of comments, but you may have some comments about incidents.
Sure, of course. So case fatality rate for seasonal influenza, it's a different measure because for seasonal influenza, the mortality is sort of defined as excess mortality, right? It's the old, sadly frail, comorbid people who, at the end of their, moving towards the end of their lives, and they get influenza, and that causes whatever underlying condition to lead to their demise. Whereas for COVID, the death rate is people coming into hospital with COVID and then passing away. It's a slightly different measure. We do have deaths every year from influenza in the same way, people getting flu, coming into hospital and dying of flu, but thankfully that's rare. The overall case fatality rate of seasonal influenza is in the order of kind of 0.1, somewhere between 0.05 and 0.1%. It's low. The CDC have sort of commented on or recorded excess mortality in North America this winter. It's been actually a bad flu season for them as well, and the mortality rate's been 0.07%, I think. So the case fatality rate for COVID is substantially higher, and we're bracing for that. In terms of symptoms, I have a slide looking at symptoms, I think. Yeah. So these are symptoms based on, this is a kind of grouping of different clusters of patients, but primarily in Wuhan. And the symptoms clearly overlap entirely with influenza. Fever is present in most. Other reports from similarly large numbers of patients show that fever occurs in even a higher proportion, up to sort of 95%. Cough seems to be the predominant symptom. You would think that dry cough, but I don't know why those numbers don't add up, but this is the report. So dry cough in most, but sputum production is not unheard of. Aches and pains, chills, nausea and vomiting. Nasal congestion is uncommon. So this is not a cold. It's unusual for people to present primarily with coryzal symptoms. There's reports, as you've all heard of people losing their sense of smell, which is peculiar. We don't normally see that with common colds or influenza. And as far as I can tell, it's impossible to tease out. The anosmia seems to occur in people who've got these other symptoms. It's not a standalone feature. Bryan.
I actually think the important one there, Stephen, is the nasal congestion, because often with colds and flus, you get nasal congestion as one of the prime things you start to see. And certainly one of the infectious disease consultants down in Wellington made that comment about nasal congestion versus dry cough and fever, and he mentioned sore throat as well. So I think, but again, the comment became that the earlier on in the symptomatology and the more mild of the cases, the more difficult to start to differentiate, I suspect. And yeah, look, it's an evolving area. I think the data is very new. What we've seen is very new, and it's evolving over time. But it's difficult for frontline general practitioners. But the nasal congestion is one other highlight.
Okay, we've got so many questions coming in, which is fantastic. So just we will just do a couple more on the flu before we move on, and if we've got time, we'll come back to it. Quick questions: how is the availability of the flu vaccine for under 3s? So, any comment there, Bryan?
Yeah, look, I don't think the those vaccines are in the country yet. It's my understanding they're not quite here for the kids. So yeah, that's the answer at this point. I'm not sure when they're due.
Okay, and are the pharmacies allowed to vaccinate individuals that don't currently meet eligibility criteria prior to, I can't remember the date in April, there's a cut-off date in April.
No, absolutely not. No.
Okay.
No.
Fantastic. And one more, I promise, before we move on. With regards to the flu immunity, the flu vaccine immunity, we know that that sort of tailors off after time.
Yep.
If we are in lockdown and obviously we are beginning to vaccinate people now, how long can we expect immunity to last in this situation?
Well, yeah, look, we know that immunity starts to drop off monthly, so your immunity starts to lower. And that's always been the case with flu vax, as to whether you go early with vaccination or late in terms of your priority populations. Or if you're going to have a late flu season versus an early flu season. Look, my comment is I think we're doing the right thing by going now. However, interesting enough, with the lockdown, you'd expect to see flu rates to drop as well, because again, it's spread through contact. So those would be the two comments I'd make. Stephen, I don't know if you've got any further comment on that.
No, I agree. And even though immunity from vaccine does drop, it doesn't vanish. We're all mostly protected by influenza from our previous vaccinations and previous flus. We've caught influenza virus episodes over the years. So no, I think early vaccine is definitely the right decision.
Just one other comment I'd make, Grace, is there has been some questions around double vaccination. Do you vaccinate later in the season? The answer is no, there's no move to do that at all.
Okay, fantastic. So let's move on to our vulnerable population. That obviously the group that we're trying to protect at the moment. So there's some questions around particularly those that are immunosuppressed or have chronic disease. How should we be managing them in the community?
Look, I'm happy to make a first comment on this. For Stephen may have some comments. I think it's basic principles what we're doing. We need to protect the vulnerable population, especially with comorbidity, and what seems to be obvious about some of what's occurred overseas or what is occurring, it's the accumulation of comorbidity seems to be a driver of poor outcome. Not necessarily perhaps age, and some commentators have mentioned that it's not age as an isolated issue, it's the accumulation of comorbidity. I think our vulnerable populations need to be protected, and I think the lockdown is a big part of that protection. So the one thing we have against being harmed by COVID is not contracting COVID, to be honest. So I think if I make a comment about general practice and what's been a very, very difficult week for frontline general practice, the move to virtualization of clinics and giving medical care in a virtual way primarily is about protecting those vulnerable populations. So that is number one. But having said that, we still need to provide care to those populations, and the majority of that care needs to be done remotely. So they still need to have contact with their general practitioner. They still be able to get medical advice and get access to scripts and things like that, and reassurance that as medical professionals we are available to them. Obviously, if they need to be seen, they need to be seen. We can't resolve from that, but hopefully all practices have got in place processes to stagger patients coming through to give protection. My final comment is things like flu vaccination are really important at this point, I believe. And we need to make sure our ability to flu vaccinate and move patients through the practices and vaccinate, having put aside the issues I've said with supply just earlier, are really, really important. And the latest from IMAC, Immunisation Advisory Centre, is obviously you do not have to have a patient sitting around in the waiting room for 20 minutes after a vaccination, that you can get them back home into isolation very quickly. So I think those basic principles are all really, really important.
Stephen, any comments around that?
So we get asked a lot about immunosuppressed patients, of course. In a hospital, we've got a huge cohort of very immunosuppressed patients, just like there are in the community as well. And yeah, it's a difficult issue, I think, where we just don't have a lot of information. I think I don't think immunosuppressed patients are necessarily more susceptible to catching COVID. And so I agree entirely with Bryan. The best thing we can do is isolate and quarantine and keep people in lockdown. I think the lockdown, many immunosuppressed patients have put themselves in lockdown weeks before the lockdown came into place. And I just wanted to briefly share the sort of data on risk factors. This is from a paper that's been submitted but hasn't been published yet, submitted to BMJ, and it's a meta-analysis. And these are the multivariable risk factors for severe disease. Severe disease is defined as basically as hospitalisation. And they're striking, but the problem we have is these aren't predictive models. These are simply statistical models. They don't actually say that if you've got CKD, you are more likely to have severe disease. It's the other way around. It shows that amongst people with severe disease, there was a preponderance of CKD, COPD, cerebrovascular disease. Some of these are almost certainly markers for other things. I should explain comorbidity. That means the presence of any of these comorbidities gave an odds ratio for severe disease of 2.6. But I think a lot of these are likely to be sort of markers, statistical markers, or that we haven't teased out yet, and none of these things are predictive. You'll notice that immunosuppression is not on the list. It's because it has an odds ratio of less than 2. And when I get asked the question about what should I do with my person who's on this type of drug or this type of therapy, I think probably the consensus advice I've read from around the world, and certainly our own department, is to stay on their treatment. I think having COVID during a disease relapse would be a potential nightmare. I think if you've got patients with stable rheumatoid, stable lupus, whatever, the best thing they can do is actually stay on their treatment until we learn more, basically.
Yeah, Grace, I'd just back that up as well. There's been a lot of questions about patients who are on sort of immunosuppressants, especially with things like rheumatoid arthritis, inflammatory bowel disease, psoriasis, and other conditions. Asthma's come up as well. I think the message has to be stay on treatment. I mean, I'm coming off treatment, for instance, with the rheumatoid arthritic patients, and we've just had some comment from Andrew Harrison and Alice in Capital Coast or Wellington, which has gone up on the college website. I mean, his basic comment was this: well, if you take them off their DMARDs or their biologics, there's more chance of flare. And how do you bring flare-ups under control? It's use of things like prednisone or steroids. And that there is a lot of talk about steroids and where they sit with all this, although it's not 100% clear, but stay on treatment. Yep. And that goes for the ACEs as well.
So just thinking about vulnerable groups, we've touched on comorbidities. Now there's just some questions coming through with regards to people that are pregnant, also individuals communities, for example, our Pacific Island and Māori communities that may be at greater risk. So at this particular point, we're expanding them into this profile of vulnerability, and how do we manage that?
Look, I'll just make some general comments. I mean, yeah, this is very difficult. The area I work in East Paurua, you have large families and family members in overcrowded houses. You have higher rates of diabetes, COPD, all the things that we've listed on the list. So it is an at-risk community. Again, it goes back to basic principles. I think the messaging about the need for self-isolation in this situation is critical in those communities, and how that's got out. I know in East Paurua, there's a lot of work going on through the churches and versus the various community groups and the iwi providers and Pacific health providers, ourselves putting out there that this is very, very important for the community. And the messaging is about the community and protection of the community. So I think these things are really, really important in our Pacific communities. I think all the things that we've got there about lockdown, physical distancing, Costney's hygiene, the work that's going on in getting the messaging out there, influenza vaccine, and the need for access to medical care and access to advice is really, really important. Okay,
that's great. I think it's probably a good idea now just to move on to the swabbing and how we should work in that space. And I think, Stephen, you've got a slide for that in your set.
Well, I do and I don't.
The guidelines.
Basically,
Okay.
I simply have the Ministry of Health case definition, which is what we're doing our best to adhere to at the hospital. The only add-in we have is that if people are admitted with respiratory illness and they're having a swab for other respiratory viruses, we're also testing for COVID. It's sort of somewhere in between, isn't it? It's kind of part surveillance and then part case finding. So all that we're doing our very best at the hospital to adhere to Ministry of Health guidelines, and I hear that's what's happening in the community testing centres as well. There's cases that are sort of somewhere in between. You know, a lot of the phone calls we're getting are, you know, my cousin's friend is possibly diagnosed from COVID and came back from Germany 4 weeks ago, and it just all gets, you know, very tangled very quickly. And we're just going back to doing our very best to follow the Ministry of Health guidelines.
Okay.
But I think they're going to change very soon.
Oh, I was just about to ask, does anyone know if they're going to change very soon? Right. Now, for us in the community, sorry, Bryan?
Yeah, I can make a comment on that. They are actively being looked at as we speak.
Mm-hmm.
I think one of the tensions in the system is the availability of swabs, which there is more coming into the country, and also lab capacity in terms of the swabs. So still the thinking is about where you get the most return for your swabbing and most yield, because that's what you want to focus on. But that is actively being looked at the ministry as we speak. Yep.
Okay. And just wondering if we can tease out perhaps a few areas of grey that we have in our clinical assessment for swabbing. For example, for health workers that will present to us with respiratory symptoms, they fit some of the symptom criteria, but they don't fit moderate to severe community-acquired pneumonia. Would you swab or would you not? So no travel, but symptoms.
Look, certainly we're pushing to swab in those situations, okay? First thing to say is anyone with respiratory symptoms in a general practice should be working remotely from home, okay, if they can. That's the first thing I've really got to emphasize here. The second thing is, the swabbing it is difficult. I think the question should be asked about swabbing those frontline workers. Certainly, there's various protocols around the country about this, but certainly one of the things that is happening in our area is we do need to touch base with the infectious disease consultant or microbiologist about that if they fall outside of the definition. That's okay, that's fine. In practice, got a reasonably low threshold. It's a conversation to work out whether you should or shouldn't. Having said that, with symptoms, if they are going to be seeing face-to-face patients in the clinic, they should be working remotely. Yep.
Okay. And I've just got a comment here, or a question I should say. Any advice for GP practices regarding if a GP gets a positive result for COVID? What do we advise the rest of our staff?
That's come up a bit. It's difficult. Stephen might have some comments on this. Depends on contact where the GP's been working, and a whole lot of issues that come into play. And my expectation is with that type of situation, public health would be involved as to what the right course of action is to do. Depending on the size of the practice, the number of staff in the practice, who's been in there, what the GP has actually been doing at that point. And I'd be saying public health need to be involved in the conversation as to the best approach at that point. One of the questions that did come up around that is if someone develops symptoms and it turns out to be COVID, how quickly are other staff members potentially likely to become infectious or develop things? My understanding, Stephen, and please correct me if I'm wrong, I think the average time to symptom and viral spreading is about 7 days, possibly less than that, up to 5. But the initial few days, even if you are in contact with COVID and you can't spread the COVID in the first few days of the close contact. Stephen, I don't know if you've got any comments about that, because it has been a concern in the sector about that.
Yeah, so I do have a slide on that, which I've just put on the screen. And we're in a phase where we're doing everything we can to try and prevent transmission, particularly in a healthcare setting, but throughout the community as well. And I think it's appropriate to be ultra conservative in this phase. But as community, or if community spread increases, we need workforce and we need to have an appropriate response. I think I agree with Bryan. If people are sick, they just can't be at work. Even if they're sick with other things. I had a surgeon call me this morning who's got conjunctivitis, and she was asking if she should have a COVID swab, and the answer was no. But she's on call tomorrow, and I said, no, you can't be on call tomorrow because you spread that virus to other staff, and then we end up with this perpetuating dilemma. And so I think being remote and not having direct contact is so important. The mean incubation period, and this is from studies of 55,000 people, 7 days, and those confidence intervals, very tight. If you haven't developed disease, if you've been exposed and haven't developed disease after 8 days, you're probably not going to. And then 9 or 10 days, it's very remote. We're using a 14-day rule, which I think is conservative. Healthcare workers are rightly worried for themselves and their families, and so I've just got a little bit of information about that. The early information out of Wuhan was terrifying. They did have 1,700 healthcare workers infected amongst the first 44,000 cases, a pretty high rate. But a lot of those infections occurred early on. They've actually mapped them out across time. And a lot of those infections occurred very, very early on in the epidemic, and very, 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 very few towards the end of their epidemic. And so it was probably occurring both two ways. One, from their own households and their own communities, and secondly, in healthcare settings, and they weren't quite geared up in using PPE as thoroughly as we already are. They brought in 40,000 healthcare workers from outside of Wuhan, and disease in those 40,000, they worked long shifts in hospitals caring for patients with COVID, and infection was almost non-existent. I found a report of 15 cases, and they were all caught it outside of the hospital base, so they're all clustered together. And so I think the risk to healthcare workers using routine PPE is actually very, very low, and I find that reassuring. Another study that has come out this morning, actually, they took samples from masks and goggles from healthcare workers caring for COVID patients in a hospital setting, and none of the masks and goggles were contaminated or had any evidence of surface contamination. And then finally, the thing that I also find really reassuring, because I've got a family at home, of course, and I'm in hospital seeing patients, is that the household transmission rate in China was low, 5 to 10%. So, of course, the living circumstances are different. The average household population size in Wuhan is much smaller than in New Zealand, or it's a whole person smaller. But then the houses themselves are different. These are small, cramped apartments and high-rises compared to many of us have the luxury of living in separate standalone houses. In the contact tracing that went on in Shenzhen and Sichuan province, close contacts, household contacts, the rate of positive pickup was pretty low, 2%, 3%, 0.9%, etc. So I find some of this information reassuring, and hopefully the listeners or the participants do as well.
Okay, one more question about swabs, and then it's a perfect segue really into PPE. With swabs, what is the accuracy like with the testing that we have at the moment?
So again, we just don't have data. We are using the current gold standard test, PCR of nasopharyngeal specimens. It's well reported that there are false negatives. So I think a positive swab is very meaningful, of course. A negative swab in certain circumstances may not be. I think when people are in the early phase of the illness with the fever and the cough, a negative swab is very meaningful. But in the late phase of the illness, so if people have had symptoms and they're in their second week of symptoms, or even into their third week, as sometimes will be the case with severe disease, then the upper respiratory tract may not be, there may not be a lot of virus in the upper respiratory tract. So in fact, the first patient diagnosed in New Zealand was diagnosed on lower respiratory specimens, not on nasopharyngeal specimens. She was well into her second week of illness by the time she presented with dyspnea. For most of the people we're testing with early stages of illness with fever and cough, I think the test is very sensitive and very specific, but I can't give you numbers because we just don't know at this stage.
Just the other thing to mention, Grace, in terms of resolution of the infection, that the swabbing at the point of resolution or thing is of no use whatsoever, because a PCR swab can stay positive for a good period of time, and so it really doesn't tell you as to when infection has stopped. So that I can tell you definitely that won't be used as a criteria for when people are non-infectious at the end of the isolation time. That question has come up a few times.
Okay, so that leads us on to PPE. It's such a massive topic for us, well, pretty much everywhere, primary care, in the hospitals. Certainly in primary care, we're in this particular situation where we often need to buy in our own PPE and we can't find it or source it. So that is an issue at the moment, and also there is some question now, because we'll be coming up to the point where we can't clinically differentiate between someone that has COVID versus influenza. How much PPE do we put on? What do we do in that particular circumstance?
Yeah, so this is problematic. I mean, we've still got a relatively very few number of cases in New Zealand, and I suppose the majority of respiratory symptoms that we see are not COVID. Certainly with a definition case, PPE has to be used. There's been a lot of talk about the masks in primary care. Should they be in 95s versus surgical masks? I mean, if the prime spread for upper respiratory COVID is droplet spread, then the surgical masks are fine. Obviously, if they're lower respiratory tract and those invasive procedures, when you start to get a SARI or a severe acute respiratory infection, you need the N95s more mask protection, but that is a hospital-based procedure. It shouldn't be in primary care. So, I mean, the surgical masks with the eye protection and the gown and the gloves, yep. The question about PPE and what happens as it becomes more confused as to who's got COVID and who's not got COVID, and whether you should be wearing PPE all day in the surgery and when you should change it. The ministry is working on new guidance on that now. That guidance hasn't come out. I think it is uncertain at this point. Stephen may have some comments about it. But the guidance has been worked on for hopefully next week to come out on this. I'm hoping it will, because it does need some clarification, because there is uncertainty in the general practice community in particular.
I think the challenge point for a lot of us in primary care when we do have to do a face-to-face is that we will go through a triaging process. So that'll be at reception, we'll ask our 4 questions, and then we'll ask again in triage. It's at the point of sit down that we find that this individual has respiratory symptoms, which I imagine is part of the concern of general practitioners and nurse practitioners and healthcare workers in general, that we don't know about exposure until they're in front of us.
Yeah, look, I agree with you, Grace, on that. However, look, our procedures at the front doors and the closed door policy and the screening that's now occurring with patients who come down and how we're screening those patients is incredibly important to this, okay? Now, patients will get through, and I totally hear what you're saying about that. But even in that situation, in the room that we have the patient, we should be thinking about trying to keep distance from the patient and the clinician. So the 2 meters, I mean, in all our rooms in our surgery, we've actually pushed chairs back. We keep a distancing policy going if we can. And remember, with close contact, there's also a time factor, again, in terms of the risk, this 15-minute close contact that people talk about. So I think we can still minimize risk in the consultation, in the surgery, and we should be taking those risk precautions. The other point I'd make is there is some advice that the clothes that you wear in the surgery, if you are seeing face-to-face patients, there's been a lot of talk about using scrubs so they can be washed every night, and some surgeries have gone to do that, but again, a lot of surgeries can't get a hold of scrubs. But coming in with t-shirts and loose clothing that you take off at the end of the day and wash, I think is good, sensible, basic advice as well.
Some of us in the community are running out of PPE, so we have been attempting to preserve, reuse. We know it's not best practice, but in lieu of really having nothing else, is there any suggestions or tips or guidance around that?
Well, there's not on reuse and things at this point. Look, I mean, this is interesting, this disconnect between the front line and the community and what the DHBs are saying about the distribution of PPE. Because centrally that's the message that the ministry is getting, that the PPE flows are good and everyone's got got processes in place. And for the majority of the country, there seems to be processes in place, but again, there's these pockets, significant pockets of the country where there seems to be problems arising. The distribution of PPE, which again is not well understood, is we have 23 DHBs across the country. They work as almost independent fiefdoms in terms of the way they work in kingdoms, and they work with their local PHOs as to how they do. And there's no standardisation across the country in terms of how PPE is distributed. That is one of the issues we have in New Zealand. There's not very hard central control over what actually happens here. And I think that's one of the reasons we've seen this variation occur across the country. In some places, it seems to be working really well. There's top-ups, there's stock being pushed out. In other countries, there's not. And it's the DHB PHO that need to be sorting that problem. And that's certainly what the ministry is saying at the moment.
Okay, I realise that we've run to time, but I think we've got lunch, so we will just go on for a little bit longer. If we can just touch base with regards to medications, whether that medications have potential benefits or adverse effects on COVID. There's so much information out there, it's actually quite hard to differentiate between fact and fiction. So if we could have someone to speak on the space of potential medications that may help with regards to hydroxychloroquine or azithromycin, and then move on to some medications that may have potential side effects.
I think I think unfortunately it's mainly fiction.
Okay.
There's a lot of desire to find something that's going to treat patients with COVID, and there's some trials that have been submitted, or trial protocols that have been, the Australasian trial protocols that have been submitted to the HRC for funding, that we're hoping to initiate both in primary care and secondary care, and then also in our ICUs. And hydroxychloroquine is a drug which in the laboratory, in a test tube, has been shown to inhibit virus. There have been studies published so far, and it looks sadly a bit useless for treating COVID. The addition of hydroxychloroquine to azithromycin increases the risks of side effects so much that we in Australasia weren't willing to participate in that international trial. The risks being QT prolongation and sudden death. The other drug that's being touted as useful in study protocols is Kaletra, lopinavir and ritonavir, a HIV protease inhibitor. Again, an early RCT shows that it causes a lot of diarrhea without any benefit. Then the problem with diarrhea, of course, is that if COVID's shed in stool, that then might create an increased risk to the healthcare workers around. So these questions aren't well known. We haven't had large multi-centre randomised controlled trials, but we've had a few small single-centre RCTs published, and the effect has been poor. The hydroxychloroquine azithromycin story comes from France, where they showed, and really a pretty, not a great study, I've got to say, but they showed viral clearance occurring slightly earlier. But there were all sorts of problems, methodological flaws with that study. And I just think those two drugs together are just way too harmful, particularly given the hydroxychloroquine on its own study showed minimal effect. So there is other drugs, remdesivir, which is a drug that was designed to treat Ebola. And that's promising from some of the reports. They're not controlled clinical trials, but some of the reports from China showed that there might be an effect, and people are very interested in studying that drug. There just aren't very large supplies of it. And so Gilead, the company that make that drug, are trying to boost production. And if it was available in New Zealand, we would add it hopefully into our clinical trials. So I'm aware of colleagues in the hospital, and I'm sure it's happening elsewhere, prescribing themselves and friends and colleagues and family members hydroxychloroquine, azithromycin, even Kaletra. And hydroxychloroquine's cheap, isn't it? So even non-funded, it's available. But you know, I think that's poor practice. I think the greater good of using these drugs is to see if they actually have benefit for the poor people suffering from COVID. And I think they should only be used in clinical trials. There are risks. QT prolongation, hydroxychloroquine can cause retinitis. You know, I think people need to factor that in. But my hope would be that people stop doing that and behave a bit more professionally, and we use evidence-based, and you know, if we get some evidence that these things work, then we've done a lot of good, and we can, you know, use them in the future. So far, there's nothing that's looking too promising to my eye. I wish that was
Now, yes, fair enough, fair enough. Now, Bryan, you alluded to before how we should keep our patients on ACE inhibitors. Is there any update with regards to non-steroidals and prednisone?
Look, I mean, I think the issue with non-steroidals is, you know, any patient who's on non-steroidals who may have any cardiac, renal symptoms, non-steroidals can potentially exacerbate that. And obviously, in the case of disease, that exacerbation is worse, especially in the presence of dehydration and things. So, I mean, you have to use clinical judgment in those situations. Certainly, if someone who's got rheumatoid arthritis on a non-steroidal control of the symptoms, they should probably stay on it. If they become systemically unwell, you'd obviously be withdrawing and stopping. So I think that's probably where things sit at this point. I don't know, Stephen might have some comments on it. I think there's been this stuff about ibuprofen in children. Look, I don't know the answer to that. All this stuff's early, but I'll just be pragmatic about it. We've got paracetamol, just use it. I mean, yeah, at the end of the day, till the answer's there, just use paracetamol. I mean, I don't think we should get too hung up about it. We can just take a very conservative approach and just say, look, that's probably the safe option at this point. Prednisone is going to be problematic with COPD and asthma exacerbations, and I think the situation is very unclear at the moment. One of the things I will say, though, very, very clearly, patients who are on inhaled corticosteroids for their asthma should stay on those inhaled corticosteroids at this point, and we shouldn't be taking them off. And I think that's the most important message at this moment. I don't know whether Stephen's got any further comments on prednisone and non-steroidals, but I think the situation is as to how that all starts to work if COVID starts to mix in the whole COPD asthma space as we go on. It is going to be a bit of a clinical conundrum. And hopefully we'll be able to sort of source some sort of practical clinical advice as time goes on. Yeah, I'm not sure if Stephen, have you got some comments?
Look, no, not so much. I think, like any viral illness around the world, we're sort of changing patterns, and I think that it's catching on that paracetamol, ibuprofen, and other things aren't useful to treat fever. They serve no purpose. I think they should be used as analgesics, and I think in COVID, paracetamol would be adequate. The reason ibuprofen's come up is because in some small case series, it's looked like a risk factor for severe disease. Hypertension, as I showed on a previous slide, looks like it's a risk factor for disease, and people have wondered whether that's due to concomitant use of angiotensin receptor blockers or ACE inhibitors. The coronavirus uses an ACE receptor on epithelial cells in the respiratory tract to gain entry into cells, but it's a different receptor. It's not that receptor is not inhibited or changed by ACE inhibitors or ARBs. There is a possibility that there's a change in upregulation that occurs when people are on ACE inhibitors or angiotensin II receptor blockers. We just don't know. And I totally endorse Bryan's comment that there's really no evidence that we should go about changing things at this point. And I also agree that if patients require prednisone, treat them with prednisone. Until we learn more, that's got to be the best approach.
Now, in social media, there is a little bit of, I guess, social advertising for particularly COPD patients to approach their general practitioners for a COPD pack, which will have a steroid and antibiotic in it. Comments on that, Bryan, and how we should approach that sort of request?
Yeah, it's difficult, isn't it? Yeah. Look. I mean, the way we practice medicine, I'm not sure that we should change the way we've done things traditionally. You know, sometimes with some COPD patients during winter, we do put them on long-term antibiotic like doxycycline and things. Occasionally, we do use back pocket prednisone scripts. I'd just do what we normally do. I don't know we have a need for COPD packs. Look, it's personally a personal opinion. I'd still be wanting to assess a patient either face-to-face or on the phone, making decisions about appropriate treatment. Yeah, look, I mean, everyone makes up their own mind about these things. Yep.
We are going to bring this session to a close very shortly. Do either of you have any final comments to make for this particular session, or looking forward as to how we can help facilitate things and help each other in practice?
Can I just make a couple of comments just to finish off, Grace, which haven't been covered? But look, first thing I'd like to say is, look, as I said, the way general practice responded to this when the call went out a week ago from the college to move to virtualisation has been outstanding. I think across the country, although it's been incredibly difficult, incredibly trying for frontline general practice, and there are a cumulative of issues going forward, general practitioners on the whole have stepped up to the mark and really gone head to head with this. And I think we can stand up and say that it was a pretty phenomenal effort over the last week. So thank you for that. Just a couple of things about core business that I wanted to highlight. I think amongst all this, although we've gone to 70% virtualisation, trying to reduce face-to-face, there are certain core business that do need to continue. We've talked about flu vaccination. I think it's really, really important. The other one we've missed is childhood immunisation. We still have the whole measles issue out there. We still have other issues with whooping cough. I think it is incredibly important that general practitioners and general practice still immunise children and have systems in place to allow that to happen. The other one that has risen this week is contraception. I would consider contraception a core service, okay? And I think we need to think very hard about our core services and what they are and how we provide them to our population. You can then start to make decisions, things like cervical screening. I would say, yeah, not necessarily a core service over the next 3 months. Can be picked up again, but contraception I'd put in a different kettle of fish. I would really, really encourage practices as teams to make decisions about these core services and how they're going to be provided, apart from the acute face-to-face that does need to occur even in this situation. But apart from that, look, thanks for all the hard work of general practice and general practices over the last week. Phenomenal. Yep.
Stephen, any last comments for us?
No, I would just echo Bryan's statement. Yeah, it's the shift in healthcare in a very short space of time is incredible, and we're seeing exactly the same thing in the hospital. It's staggering actually how people have not run and hid from this and ducked for cover. They've stepped up, and we have full COVID teams ready to run as of Monday. I think getting to the phase we were almost prepared. I might change my words in that in a week or two, but yeah, I think we're seeing the same thing in secondary care, and we are open for business as usual as well. I think there's a bit of an idea that patients need to stay in the community, and we don't want anyone suffering. So for now, we're open for care, and if patients need to be in hospital, they should come to hospital. Great.
Thank you so much for both of you for taking the time out of your very busy schedules for talking to us today. And also everyone that typed in their questions. I'm sorry we couldn't go through all of them. There were so many. I know there's a lot of things around COVID that we have questions about. Thank you everyone for joining us, and see you again soon.